Okay, so today we're going to discuss a new tool that we're going to be introducing to the facility. Now, for the last 8 months, you guys have been doing a wonderful job with the weekly wrap-up, tracking your numbers, seeing where your patients are, doing your active patient reporting, checking in with your patients. So great job on that. But what does that all mean? What are those, we've been tracking these numbers for 8 months now, and what does it all mean? Why are we tracking these numbers? So that we can get more patients in? Maybe. So that our numbers are up? Maybe. But is that really what matters? I mean, why did we get into this profession? Why are we PTs? Essentially to get our patients better. So our focus is getting our patients better and having them have a successful experience here and having them reach all their goals. And the best way to do that is to give the patient a tool in order to have that happen. Now, we're tracking our numbers, we're seeing where our patients are, but one of the things that we're not tracking is how many of our patients are truly graduating successfully. Now, we have a little section about, on the weekly wrap-up, successful graduations, but what's the definition of that? What does that mean? Who are we putting in that category? Anybody that's put a number in there, who are we putting in that category? Danielle?
Like a pre-plan, they've met all their benchmarks, ready for independent management.
Okay, that's what some of the patients that you're putting in there. Great. Who else are you putting in there? Same. Met all the goals? Okay. Who came up with those goals? You and the patient together, sat down, wrote them down, didn't write them down, just talked about them. And then one day was like, okay, our goals are met, you're done, successfully graduated. Great, good. That's a successful graduation. Someone that's met the goals that you and the patient came up with together and agreed on, and they met them. That's a successful graduation. The national average of successful graduations from a PT facility is less than 20%. That means less than 20% of the people attending physical therapy are successfully graduating. Does that mean we stink as clinicians? There's bad patients. Yes, that's true. But not 80% of our patients are not bad, right? It's not the skills of the clinician. It's the definition of the successful graduation and coming to terms with those, with the patient and agreeing upon them and then executing them. That's why the patient doesn't successfully graduate, because they don't know what they're supposed to be doing. They don't know when they're supposed to be coming in. They don't know what the plan of care entails. We are the experts in that, and it's our job to guide them. They're coming to us for guidance, and we have to give it to them. They're looking for that. And if we don't give it to them, they're either gonna make up their own or not know, period, and be too afraid to ask, or just kind of wing it. And in the end, that graduation of the patient of meeting their goals is not gonna be met. So, what needs to happen in order for you to do that? When you have something wrong with you, like an infection or a cough, let's say, do you go on Google and look up your symptoms? Yeah, right? You can go on Google and like, I have this cough. But what does Google tell you?
You're dying.
Anything from you have a simple cough to a terminal diagnosis, right? And so you read all of that and you become overwhelmed. And what do you do after that? You go seek the guidance of an expert. And when you go seek the guidance of the expert, what does the expert do? tells you exactly what to do and when to do it and how to do it. That expert, aka the physician, the doctor, doesn't say, well, you could take these when you have a chance, take these antibiotics when you have a chance. It's okay if you can't take them this week, but if you kind of take every once in a while, eventually you'll get better. Does that happen? Is that what the doctor says? What does the doctor say when he prescribes antibiotics? Take these every day for the next 10 days, and if you don't take these for the next 10 days, the chances of you getting better are slim. And what do? We follow that because the expert told us to do that. The person that we trust, the person that studied this, the person that understands what the end result is, told us to do that, and so we do it. And the same thing goes for physical therapy. A patient is in pain, has an injury, whether it's acute or chronic, is going to come to us seeking guidance on how to get rid of that pain and how to get rid of it recurring. So not just getting rid of the pain that they're in right now, but how to not have it happen again and have you execute that for them and tell them how to do it and when to do it and how often to do it and what it takes to do it based on what they want to achieve. A simple goal of just getting rid of pain is exactly that, too simple. You want to work on not just getting rid of the pain, but teaching them how to not have it recur and having them go back to the high level activities that they were doing. So when they come in for their initial evaluation, seeking that guidance, it's our job to give that to them. It's not just our job, it's our obligation as physical therapists. It's what we signed up to do. So, how do we do that, right? Simply telling them schedule twice a week for the next 4 weeks and we'll see what happens. Could, but it doesn't always happen, right? We know that. They go to the front desk, what happens at the front desk? Well, I think I'm supposed to come in twice a week. I can't do this week. I don't know. It's okay if I skip next week or I'm doing this. Okay, so let's just do 2 Tuesdays from now, I'll do one, and then 3 Tuesdays from now, I'll do another one, right? That happens more often than not. That's the 80% of that 20%. Again, has nothing to do with clinical skills. It's just they don't have the guidance from us and the prescription from us to execute this plan to successfully graduate. Again, we're in the business to make patients better. In order to do that, we need to tell them how to do it, when to do it, and in what fashion. So essentially, we need a tool to do that. And that tool is there in front of you. It's called the Successful Rehab Plan. And I'm going to show you a little video on the Successful Rehab Plan. It explains it better. Travis will be explaining it to you. He explains it much better than I will ever explain it. He has several clinics in Pennsylvania. Several years ago, before implementing this Successful Rehab Plan, his successful graduation rate was below 20%. After implementing this, his successful graduation rate is close to 90%. Just from implementing this. None of his therapists changed anything in terms of their treatment. None of their therapists became higher level skilled therapists. Just gave the patients the guidance in order to execute this. So I'm going to have Travis explain to you the Successful Rehab Plan contract.
Tomorrow, but this is a Successful Rehab Plan. Has anybody seen this besides Audrey? So this is a tool that we use at every single initial evaluation. Contract is a strong word, depends on what's happening with the patient if I encourage the use of that word, but this is an agreement that we have with the patient on the plan of care. So we try to make this as simple as possible. I have a bunch of different versions of this. I have one where in the blank space here, I have our ancillary services, nutrition, laser, massage, all that stuff for an opportunity to get conversations started with patients. I took that off because I just wanted to focus on this. Like, this is the initial steps of this. So every single initial evaluation in our organization, this has to be filled out. If you don't get your note done, if you don't get your HCP set up, if you're backed up on any other stuff, I'm okay with that. I'm not okay with the patient walking out and not going over this document. In initial evaluation, you throw a lot of stuff at a patient, right? So it's hard to keep all that stuff organized, and this is the way that I do this. I use this as a checkoff system because my memory's crap. I have crazy ADD, and if I didn't have this, I would forget how to do things. I've been doing it for a while, but I might not forget how to do it. But certainly for new clinicians, you're gonna need something like this to help them out. This is gonna seem extremely simple, as because it's designed that way. So I have up here, one we'll just kind of point out a couple things. Primary complaint. So this isn't a diagnosis. Their primary complaint is what they're coming in for. So typically neck pain, back pain, shoulder pain, something like that. And then the actual physical therapy diagnosis. This is really important. You need to diagnose them with something. You guys paid for doctorate degrees. Why? Because you needed to be able to tell the medical industry that you can actually diagnose people. So if they walk away and it says physical therapy diagnosis, shoulder pain, that's not a diagnosis. That's a symptom. You gotta tell them exactly what's going on. Are we 100% accurate every time I diagnose somebody? Do I know for 100% that this is more a supraspinatus irritation versus a labral tear? You know, the metrics on those are not 100%, but I'm confident in my ability to diagnose somebody, and I'm not always right. I'm okay telling the patient that, but I've got to give them a diagnosis, because what are they going to do when they go home? Their significant other is going to say, what's wrong with your shoulder? And if they say, the PT said I had shoulder pain and really couldn't tell me what was going on, it's just not going to go well, right? What kind of confidence are you going to have in a clinician that can't diagnose what's going on? You have to be able to master this skill. And again, I'm not right 100% of the time. I'm right more often than I'm not, but you have to have a diagnosis there. Here are all the problems that we went over. So when you're doing testing with a patient, there's lots of things you're doing, right? Special tests, nerve glides, all sorts of testing, and telling them all these problems that they have. And then you have to organize that at the end in a wrap-up. So that's when we do this, we kind of go through, here are the things that I said was going on. I've never had a patient say, can we just speed this up because I already memorized all the stuff you told me in the last hour. It doesn't happen. So repetitive things like this are really important. Primary goal for physical therapy. This is the second most important thing on this sheet. You need to dig out their goal. What's the most common goal you hear from a patient? What are your goals in physical therapy? Rid of the pain, right? If I ever see get rid of my shoulder pain as a therapy goal, that's like an immediate call from me. So we review these, although haven't seen it in a while just because we drill it in so much. But if I ever see a really crappy goal, then that's a problem for me. So I'm wondering if what goal is being set up and other things. So getting rid of shoulder pain is not good. If a question I use a lot is, okay, we're gonna set up your goals here. So what are you not doing now that you would do if you didn't have this pain? Versus what are your goals in physical therapy? I want to get rid of the pain. Okay, good, that's easy. Get rid of the pain. What are you doing now that you'd rather do without pain? So do you ever had a patient? I do everything. I push through it. I have a very high pain tolerance. I think that's another 75% of people say they have a very high pain tolerance. I have a very low pain tolerance. I have no tolerance for pain. So anyway, I have a high pain tolerance. I just do it anyway. It's like, well, wouldn't you rather do that without pain? Oh yeah, sure. Okay, so what are the things that you're doing now with pain you'd rather do without pain? Like, oh, this and this and this. It has to be, I hate the word functional, but let's use it. It has to be something that is functional. You know, if you're reporting to the insurance company and we're talking about authorizations and issues that, yeah, patient is really tired on the back nine. Like, they need to really improve their golf endurance. Like, probably don't put that on there, okay? So you've got to find something functional. So it would be like, patient has difficulty with high-speed rotational activity. I need to get better at golf. But it's got to be really clear, and it has to be compelling, because you're going to ask this person to sign up for 3 hours a week of just in therapy, maybe 15, 20, 30 minutes. I don't know, I'm sure traffic is pretty rough around here at times, maybe longer than that, to kind of come in and then spend that time and then do that for a significant amount of time and have a deductible, copay, co-insurance. Like these goals have to be compelling, so you have to focus on it. That's the second most important thing, because this is the first most important thing. This is your prescription. What do you prescribe? Jeremy talked a ton about that. I won't go into it too much, but it has to be specific. And when you handle objections, you have to be able to be confident in those objections, which we'll go over. But I'm sure you guys have gone through and said, hey, I need you to see you 3 times a week for the next 4 weeks. Let's just say that. Have you guys ever gotten an objection to that? So they'll say, time, money, distance, which we'll go over another slide. That's usually the problems that they have. We're going to teach you how to handle those objections. They don't have a 100% success rate on doing that. You ever treat guys that work night shift, and it's like, I work 12-hour shifts, and it's when you are open. How am I going to get here? I have like half days on Tuesday and Thursday. I want you to come in 3 times a week. And so if you tell that patient, oh, you can only come in 2 times, okay, that'll be fine. Like, if that were me, like, what would I think as the patient? I'm kind of like, well, why does this guy want me to come in 3 times a week when it appears as though 2 times a week is just fine? Apparently he just wants to like charge my insurance company and make money. So you have to be able to defend this stuff. And then we have them sign it at the bottom. This is very specific stuff. And whenever we get pushback on stuff, we will bring this piece of paper out and we will show them, remember when you signed this? Now everybody, they sign a lot of stuff typically on their initial evaluation, right? But it is an agreement that we made and you signed up for it. If your therapist half-asses this and just kind of fills crap out and doesn't do a good job of explaining it, then it loses its power, but they've signed it. It's an actual agreement. I know it seems simple and it doesn't seem like something like this would be super effective. The practices that we work with that use this see like almost universal improvement in their successful graduation, just for this like one little tool. It is an extra step. Your therapist are going to have to do a little bit more work, but it.
All right, I know the volume was a little low, but you got the gist of it from his explanation. So it's an extra step during the initial evaluation. It's going to be in each of our initial evaluation packets, and it's going to be a form that the PT and the patient goes through together. Fills it out, and the patient signs it. The patient then walks this paper up to the front desk, because on this paper is the actual prescription that you are prescribing for physical therapy. And there's 3 lines, and the reason why there's 3 lines is because it's not always black and white, twice a week for 6 weeks, 3 times a week for 4 weeks. Sometimes it's 3 times a week for 3 weeks, and then twice a week for 6 weeks, and then twice a week for 4 weeks, or once a week for 4 weeks. So that's okay too, to break it down that way. And they're going to take what you write here to the front desk, and the front desk is going to schedule that out according to your prescription. Any questions on that? Yeah. Yoshi.
And I guess that also depends on what the prescription from the doctor says? No. Okay. No.
Prescription from a doctor is guidance, right? Most of the prescriptions, what do they say? 2 to 3 times a week for 12 weeks. I haven't seen one that was like specific twice a week for 6 weeks and then like that's it. 2 to 3, especially the electronic ones that are coming in now. 2 to 3 times a week for 12 weeks. Some of them have an expiration date that's 1 year from today. So, no, the electronic ones that are coming in now are completely open-ended. So don't worry about that. Okay. Well, that's where your clinical guidance comes in. Where you're saying they scheduled out the prescription, right? And then something happened and they have to cancel. Yeah, then you take your clinical guidance. What's important is that they schedule out this. Because what you just described is a 1% anomaly, not the 99% of the patients that walk up to the front desk, right? So something happens in their family or something happens to them, whatever. There's a million different things that can happen, of course, but we're talking about the patients that walk up there after initial evaluation, even though you told them that you want to see them for twice a week for the next month, and they walk up there, and front desk, correct me if I'm wrong, schedule one appointment. Schedule one appointment. Where's that one appointment coming from? You just told them to do twice a week for the next month. Does that make sense? Yeah. On the weekly wrap-up, we have that line that says how many of your evals scheduled 6 or more. So you guys know from filling that out, the number is usually on the lower end, right? The reason why that's asked is because, again, that's a telltale sign of whether or not the patient is going to fulfill their obligation. Because in the end, in 6 weeks, in 8 weeks, whatever it is, they're gonna go back to their physician for a follow-up. When they go to their physician for a follow-up, and they're not 100% better, they're gonna say, I went to physical therapy and I'm not better, it didn't work. The physician never asks, how many times did you go? The physician doesn't know that the patient came in twice over the last 6 weeks. Of course you're not gonna get better. How do you get better? Right? So, and this is a way that, you can document that you told the patient and the patient agreed that this is what is needed to get better, to fulfill those goals. And you're very clear with your goals, and they're high-level goals. Like the video said, not just get rid of the pain, but actually getting to higher level stuff. Playing with the grandkids, walking to the supermarket, picking up the groceries, bringing them back home. Patients want to do that, but they forget to mention those things unless we bring them up and remind them. Okay? So starting tomorrow, this will be in your eval packets. You're gonna pull it out. You're gonna fill it out. You're gonna come up with the goals with the patient, come up with the prescription, have the patient sign it, give it to the patient. They'll walk it up to the front desk, and the front desk will fill his prescription. And then how do we know they actually successfully graduated? Well, when they're done with their PT with us, we are going to give them a very informal survey, which is the second page you guys have in front of you. This is the Net Promoter Score. If you guys have ever used a service or bought something online, you usually get a text message or an email that says, how did we do on a scale of 0 to 10? Well, that's a Net Promoter Score. A 0 is, 0 is not good, 10 is the best. But basically the question that's asked is, how likely are you to refer us to a friend or family member? Because that's the highest sort of compliment, right? Highest form of compliment is having someone tell their own relative or neighbor that they trusted us enough that they should come here as well. So on a scale of 0 to 10, how likely are you to refer a friend or family member to us? A score of 9 to 10 is they are likely. Anything below than that, they're not likely to refer someone to us. And if they're not likely to refer someone to us, it means we did something not right. Either we didn't fulfill their goals with them, or we didn't explain this process right. We did something that wasn't to their satisfaction enough for them to trust someone else to come here. So on their last day here, the front desk will be asking them this. We'll be giving them this paper, essentially, and they'll just have to circle the number, okay? And if for whatever reason they walked out of here and that didn't happen, the front desk will be emailing or calling them and getting that number. Or if you happen to be talking to them on the phone because they weren't in and they end up saying that they're done with us, because they finished, they're feeling better, you can ask them this. But that's the least likelihood of, that's the last resort that'll happen. Most likely it'll be the front desk that will be taking care of this part, okay? And that will be considered a successful graduation. Yoshi.
Yes. Can you kind of talk about how we have this part of the conversation if, like, the patient can only come in certain times a week or they're going on vacation? How do you, like, go around? How do you handle it?
Well, there's different scenarios, right? If they're coming to you on Thursday and then they're going on vacation for the next 3 weeks, that's problematic, right? So obviously, you say, okay, you're going on vacation for the next 3 weeks. Our schedule is now open for the next 4 or 5 months. So there's no excuse to not schedule their appointments ahead of time. No problem. I'll give you some exercises to do just to sort of buy some time between now and then. But when you come back, you need to start this prescription. So go ahead and schedule those now because the schedule is open.
What about if it's like, I'm going away in like 3 weeks? Like, how do you fill this part out knowing that's coming up?
So they're here for 3 weeks. So you want them coming in how many times over the next 3 weeks?
Twice a week.
Twice a week over the next 3 weeks. So the first line will be twice a week for the next 3 weeks. And then they're gone for how long?
2 weeks.
2 weeks. Okay. So they're gone for 2 weeks. That's okay. What do you want them doing when they come back?
Next 5 weeks, twice a week.
So then the next line will be twice a week for 5 weeks.
Okay.
In the end, it's not more visits. Know that. Know that it's not more visits that we're getting, right?
Right.
It's taking those visits that you would have spread out over months and just consolidating them over a short period of time for 2 reasons. One, for the benefit of the patient so they actually get better. When a patient comes in once a week over 12 weeks versus 3 times a week over 4 weeks, who gets better quicker? Who gets better? The one that comes in for 3 times a week over 4 weeks versus once a week for 12 weeks. Once a week for 12 weeks and 3 times a week for 4 weeks is still 12 visits. So we're not gaining any more financially. So just know that part. It's to make them better. When a patient's better, they sing our praises from the rooftops. I don't know about you, but I'd like to work for a place that has a success rate above 80% of getting their patients better. I think that's something to boast about now. Like, hey, my place gets 80% of our patients better. Does yours? Oh, you only get 20% of your patients better?
So if a person is like, okay, I just can't do twice a week, right? Then when you fill this out, do you put once a week then, or do you still put twice a week and let them know, well, you're not going to get better faster this way? Like, how do you?
I think these are all conversations that you should be having with your patient.
One second.
Sorry.
So, but why? Your question to them is why can't they come in twice a week?
Work. I don't know. I'm just imagining situations where I trip up on this part.
You trip up on this part. It's because we're not used to this part. That's why you feel like we're gonna trip up on this part. But Yoshi, if you go in with that mentality, you're gonna trip up on this part. You need to flip the script. You just spent the 45 minutes prior to that convincing them how you're going to reach their goals and what needs to be done in order to reach their goals. So what if you went to the doctor and he said you need to take these antibiotics every day, and you say, I can't? What will the doctor say back to you?
I feel like we're comparing different things, but I just want a general guide. Like, no, you know what? Never mind. It's fine. I'll go through it with a different mindset. I just wanted like a little bit more concrete, like a little bit of a how to navigate. But it's okay.
How to navigate is take your expertise, your skills, your reasonings, and tell the patient what's needed to be done in order for them to get better. Say, it's going to be hard for us to achieve these goals that we just talked about.
Okay.
So is there any way that we can maybe do twice a week for 2 weeks? And then once a week for 2 weeks and see how that goes. Negotiate with them, but not just a negotiation, but with justification behind it. You just spent 45 minutes evaluating them and they told you their goals and you told them how you're gonna reach those goals. You can't reach those goals just because we talked about them. right? You're telling them what needs to happen. And it's actually not comparing two different things. If a doctor prescribes what to do in order to get it done and you don't do it, it's not gonna get done.
Okay.
Agree or no?
I mean, I think it is still different things because the amount of effort you need to do to take pills is very different from coming into a place and spending time.
Not somebody that has an aversion to pills,
Okay.
right? The blocks may be different, but they're still blocks, right? If you tell somebody what will happen when they come here and what the outcome can be if they come here and see you, you can convince them. I think.
Okay, so what, never mind.
Never mind, because
If you can't convince a person to come in multiple times a week, they're just, I can only do once, then do you put once a week? That's,
are you looking for an answer of what to write down?
yes.
I think you should think about yes, you put once a week,
Okay.
but then we're gonna have a discussion about it because you're gonna then tell me what were the reasonings behind the once a
Sure.
week
Mhm.
and why you couldn't convince them that once a week wasn't enough.
Okay.
So I think you should focus more on what you need to be telling the patient rather than what needs to be written here. There's no right or wrong answers here, other than the goal section, but there's no right or wrong answers here. This is for the patient's sake. You want them to get better, right? Right.
Yes.
Right, so this is the tool to get them better. They need tools, and we need tools, but they need tools too, and they need guidance and they need to be told what to do. They're looking to us for that guidance. We should be able to provide that. Does that help a little?
Yeah.
Before I move on to the next thing, any questions on that specifically? Yes.
Other than them telling us that they graduated, but the one that won't tell us, how would we be discharged?
Yeah, well, if it's their last visit on the schedule, you're gonna ask them why it's their last visit, right?
Well, other than that, because yes, we'll ask them, but if they have like a whole week schedule, and then they just go, we see you, and then.
If they're scheduled and they cancel those appointments, you mean?
No, just in general, like, would the therapist tell us that they're being discharged, outside of the patient telling us that they're being discharged or graduating, or will we be notified by the therapist?
I don't think it's not a notification system, but you guys can communicate with each other, for sure. But there's no notification system.
No, not.
Yeah. But-
For instance, if the patient's leaving, they'll be like, oh, such and such is being discharged, we can cancel their appointments or stop them on their way out. Sometimes they won't stop, sometimes they will stop, sometimes they'll tell us that they graduated, sometimes they won't, so.
But if they're walking out of here and they don't have another appointment scheduled, don't we ask them to schedule another appointment?
Yes,
Okay,
We do.
and they say, oh, I'm done with PT.
sometimes, yes.
Okay,
Yes.
and another scenario is
They
they're.
call or I'll email.
Okay, if they say I'll call, then yes, you need to tell the PT, patient is not scheduled for any more PT. Are they done? And if they say no, then we need to take our next steps to contact the patient and get them scheduled. That's where the PT comes into play, that they have an active patient report that has them listed down as not scheduled. Yeah, but communication, for sure. But yeah, if they don't have anything scheduled, then
No, we usually stop.
and they'll say, oh, I'm done, I'm all done. Yes, that's when you pop this paper out, hand it to them, have them circle it.
Oh, do we need to do it for like waivers? If you know the issues that won't affect your grades, if you know next year.
If you want them to be successfully graduated, if you want them to count as your successful graduation rate. So our active patient reporting is gonna change a little bit in terms of what it looks like. There's gonna be 3 categories. The first top category is gonna be active patients, like you have now. And then next 2 categories are going to be successfully graduated and unsuccessfully graduated. Unsuccessfully graduated are the ones that dropped out. We haven't heard from them. We attempted to call them 3 times, contact them 3 times, and we didn't hear back and never scheduled. They're discharged. I don't wanna see them on the active patient report. They're no longer an active patient. They're discharged, but they're discharged unsuccessfully. They graduated unsuccessfully. So if you want them on the successful graduation section, then yeah, they need to fill that out. Just because they come back doesn't mean they really like you. Any other questions? No. So, in the end, on your weekly wrap up, right, you have a line that's called visit frequency. You guys know that line, right? It's the one where the number is 1 point whatever, and the goal is 1.8. And for most of us, it's like 1.3, 1.4. That's how many times a week the majority of your patients come in. So if the majority of your patients come in 2 to 3 times a week, that number will be closer to 2. If the majority of your patients come in 1 to 2 times a week, that number will be less than 1.5. Okay? And if that number is low, that means your schedule is not filled. If your schedule is not filled, that means your active patient number is low, which means that you need more evals on your schedule to increase your active patient numbers to increase your load. So the more frequently your patients come in a smaller time frame, the less evals you'll have on your schedule. Does that make sense? So if you have a patient that comes once a week for 12 weeks, or twice a week for 6 weeks, still 12 visits. So same number of total visits. But if they only come in once a week, you have extra slots on your schedule available. Those extra slots are going to be filled with evals. If all your patients come 2 to 3 times a week and they schedule out, you don't have room for evals. That's the goal. Don't have room for evals. Yoshi, how many evals did you have this week? Or last week?
Oh, last week.
It was a lot.
I think everyone.
I think you might have had it most.
Oh,
Yeah.
Small.
Yeah. Yeah, we had 39 evals last week. It's a lot. It's a lot. It's a lot to have more in 1 week. Right? But if you don't have room in your schedule, there's no room to put them. No room for the follow-ups. Right? So have your follow-up schedule out for 2 to 3 times a week, and they'll be happy because they'll have their appointments. You'll be happy because you'll have no evals. I'll be happy. Front desk will be happy because there'll be less evals. Does that make sense now? So the weekly wrap-ups that we've been doing, this is what it all sort of culminates in, getting to our successful graduation for our patients, making them better. Okay? Any questions?